All right, welcome back, everybody. I hope everybody enjoyed lunch. I'm now going to ask Mike Edbauer, president of Highmark of Western and Northeastern New York, to come up and help us introduce and moderate the panel for our afternoon kickoff. So Mike, come on up. We'll be talking about understanding universal health care. What are the options?
Okay. Actually, I'll ask the panelists to come up and join me on stage, if you don't mind. Everybody get situated. And good afternoon. As Eric said, I'm Mike Edbauer. I'm president of Highmark, Western Northeastern New York. Very happy to be here today. And pleased to be able to be the moderator for this session of Understanding Universal Healthcare. What are the options? So at this point, just would like to introduce our panelists. So we're going to start the session in a moment with a presentation from Chris Pope. Chris is a senior fellow at the Manhattan Institute. Previously, he was director of policy research at West Health, a nonprofit medical research organization, health policy fellow at the U.S. House Committee on Energy and Commerce, and research manager at the American Enterprise Institute. Chris's research focuses on healthcare payment policy, and he has recently published reports on hospital market regulation, entitlement design, and insurance market reform. His work has appeared in, among others, the Wall Street Journal, Health Affairs, U.S. News World Report, and Politico. We also have with us today Lauren Crawford Shaver. She is the executive director of the Partnership for America's Healthcare Future. Previously, Lauren served as the director of expansion states for Hillary for America. Before serving on Secretary Clinton's 2016 presidential bid, Lauren worked in the Obama administration as the Deputy Assistant Secretary for Public Affairs for Healthcare at the Department of Health and Human Services. At HHS, Lauren managed all campaign issues tied to the Affordable Care Act, Medicare, Medicaid, Health IT, prescription drug pricing, health centers, and other health research. That's quite the list. And then we also are pleased to have with us Nadim Asmail, Senior Fellow with the Fraser Institute. Nadim first joined the Fraser Institute in 2001, served as Director of Health System Performance Studies from 2006 to 2009, and has been a Senior Fellow since 2010. Nadim has spearheaded critical Fraser Institute research, including the annual Waiting Your Turn, which is a survey of surgical wait times across Canada, and also the How Good is Canadian Healthcare, an international comparison of healthcare systems. Additionally, he has authored or co-authored more than 30 comprehensive studies and more than 150 articles on a wide range of topics, including the cost of public healthcare insurance, international comparisons of healthcare systems, hospital performance, medical technology, and physician shortages. So we have a very impressive panel here. So again, welcome to all our panelists, and I will turn it over to Chris to get us kicked off.
Thank you very much, and thanks to everyone for coming here today. I'll get right into it. Obviously, everyone here went through the presidential campaign in 2020, and so will be familiar with a lot of the rhetoric surrounding single payer, universal healthcare. And we've had a strangely quiet time in terms of health policy relative to the past 10 years, I think, since the last election. And so it probably gives us a little chance to step back and sort of think about some of these issues more soberly and sort of think about what are the ways we can actually move forward sort of out of the fray of electoral politics and sort of get a sense of direction a little bit more. So I think the first thing that I like to think about with single payer is that there are really two versions of single payer. There's the campaign version of single payer, which is generous promises. It's we're going to give everybody everything they could possibly want, and it's not going to cost them anything. We're going to get rid of everything that people really don't like, those annoying claims reviews, out-of-pocket costs, gatekeeping. basically all the forms of cost control. We're going to set those aside. We're going to expand the benefit package. We're going to add vision. We're going to add dental. We're going to add long-term care. Obviously, this is enormously expensive. The RAND study of the New York Health Act figured that it would add 18 percentage points to the state income tax if you did this. But if just 0.5% of people left the state because of this additional marginal tax increase, you would have to go to a top rate of 88.5%. We're talking about fantastical numbers that are entirely infeasible. Vermont, obviously a very liberal state, also ran the numbers, entirely wanted to go the way of single-payer healthcare, this generous, expansive version of single-payer healthcare. And it was entirely unfeasible, not because the legislators didn't want to make it happen, not because the staff didn't want to make it happen. Just the numbers didn't add up. The promises were far too expansive. So I think if you're actually serious about single-payer healthcare, and if you think about real existing single-payer healthcare in the world, it's not this expensive, generous, you can have everything you currently have and more, but it's what you could think of as single-payer on the cheap. In the RAND study, they talked of supply constraints, which is a bit of a euphemism for rationing and denials of care. And that's an essential element of real existing single-payer around the world. If you actually sort of look at what countries are spending on healthcare, there is not a free lunch to be had. The United States has prices that are relatively high. Obviously, on the private side, prices are very high. But if you think of all payer prices, which are across Medicare, Medicaid, and private insurance, the United States actually isn't that much of a huge outlier in prices. But our volumes are much higher. So if you want to bring spending down to an international level in terms of healthcare, you're mostly talking about reducing volumes of care, reducing access to care, and that necessarily means waiting lists. Single payer spends less, and this is mostly because people get less. That's the simple trade-off here. If you think about things that we take for granted, standard primary care, going to visit an OBGYN, seeing a specialist, getting scheduled surgery on time. These are things that Americans take for granted. It's not a small disparity that we're talking about with the single-payer countries like Britain and Canada. It's a very, very large disparity. And waiting for healthcare is not like waiting for a new piece of furniture to be delivered. You wait for furniture to be delivered, and if you're waiting 6 weeks or 2 months, okay, it's not a big deal. It's still the same piece of furniture. But if you're waiting for healthcare, that during your wait, your condition will get worse quite often. People will end up with a condition that could have been treated promptly becoming inoperable, or something that can, like a form of cancer, no longer being treatable by drugs that are available or should be available. And so it's a much more serious problem to have a shortfall of healthcare or a waiting list for healthcare than it is for many other goods and services. So I think this is the reality with single-payer healthcare. We have this issue with shortfalls. We also have the fact that with single-payer healthcare, where is the big change going to be? Your big change isn't really on Medicare and Medicaid. We already have publicly financed programs that take care of the poor and the elderly. The big change with single-payer healthcare would be everyone who isn't poor and everyone isn't elderly, all their costs would be assumed by taxpayers. So the great bulk of the costs associated with single-payer healthcare would basically be an enormous subsidy to people who currently pay for their own healthcare or whose employers pay for their own healthcare through employer-sponsored insurance. To the extent that employer-sponsored insurance pays a lot more for equivalent medical services, to the extent that it suffers price discrimination from hospitals, these additional costs would be brought onto the public sector balance sheet, and you would need to raise taxes across the board. So if you're thinking about from the perspective of the poor, the elderly, the disabled, what would they see different? Well, they largely would keep getting Medicare and Medicaid as they currently do, but they would face higher taxes because they would be paying for all the upper income people who are currently paying their own way with employer-sponsored insurance. So it's really the opposite of a targeted solution. It's expanding the public responsibility to bring the costs for upper income people onto the public balance sheet, rather than a targeted solution filling gaps in care. The next issue is that I think kind of, as we saw the 2000 presidential primary campaign progress, the idea of forcing everyone into a single payer system that maybe would give them less and maybe push up their taxes, the downsides of that were pretty obvious even in a Democratic primary, and the candidates backed away from that, and it got replaced by the idea of a public option, a voluntary sort of system if you wanted to be part of it. But then that just really kind of begs the question, to what extent would a public option be different to the various private options that we already have? The exchange plans under the Affordable Care Act are highly regulated. The benefits are very clearly stipulated by federal law. States are even more prescriptive in many cases. Funding is to a large extent from the public sector. Rules in terms of benefits and networks are all highly prescriptive. So to what extent would a public option be different from the various private options that currently exist? Do we mean narrower networks? Is that how they would save money? They would basically be subject to exactly the same trade-offs that policymakers are currently dealing with private options in the exchange. There is, again, any kind of state law that you could imagine to add a benefit or add funds to the exchange plans, you would have exactly the same policy debate with a public option. It doesn't really change anything. To the extent that a public option would be advantaged by regulation and law relative to other competing private options, you're kind of moving away from it being optional. So there's really a spectrum. To what extent would a public option really be optional? In which case, if it's not, it's just single payer in disguise. And if it's entirely optional and on a level competitive playing field with private options, to what extent is it just a private plan with a public approved sticker on it? It doesn't really get you out of the trade-offs that we currently face. There is an idea out there that we could save a lot of money just by being prescriptive with reimbursement rates for hospitals. I think anyone who's looked at the debate with surprise billing over recent years will appreciate how difficult it's been to really squeeze hospitals' ability to bill, even in the most egregious circumstance like the out-of-network surprise billing context. I think it's fanciful to imagine that you could really squeeze rates substantially across the board, not just in the most egregious circumstance where a patient isn't choosing and where you would apply in-network as well as out-of-network. So I think that the single-payer debate was really a campaign applause line more than really a serious attempt to grapple with the complex, nuanced, and granular trade-offs that we think of with health policy. If we think about healthcare spending, the government is already the dominant payer in the American healthcare context. It varies a little bit between the subsectors of the healthcare industry, but the hospital industry is profoundly shaped by Medicare and Medicaid. These are the dominant players. The extent that Medicare and Medicaid have features of their payment policy basically shapes the entire industry. Anyone who's worked in a legislature on Capitol Hill knows that public payment rates really determine the shape of the industry, and the lobbyists are very acutely aware of this. So what trade-off is really being proposed here? And I think the best way to think about it is to kind of set aside the issue of the public option and single payer. In some way, these are kind of vague generalities that kind of distract us from the incremental trade-offs that we're always dealing with in health policy. So I'd like to talk about a couple of ways to think about this. Firstly, the issue is not so much universal versus non-universal, but how much and who pays for it. Now, these are the two essential issues that anyone who's worked in health policy deals with every single day. What does the benefit package cover? How much are providers reimbursed? What services are covered? To what extent is quality differentials accounted for in reimbursement rates? How does this relate to private insurance? And how are these costs distributed between taxpayers, premium payers, employers, and so on? When we think about entitlements, we think about Medicaid, we think about Medicare. We have these huge debates about incrementally expanding these programs, and those are entirely worthy debates to talk about. I mean, there is no perfect answer to where the line should be drawn in terms of who should be given entirely free care in Medicaid, who should be given subsidized care through an exchange, what should the terms of these subsidies be. These are complicated debates. To pretend that you can just kind of wipe away these debates by talking about a public option and single payer is just to assume that these trade-offs and difficult dilemmas are going to go away by ignoring them. The third issue, which is, the third point that I'd like to talk about here is potential options to, instead of complaining, I guess, which I've done a lot about thus far, is really how to really improve something in a way that offers us a way out of what I think is an impasse that's frustrating for pretty much everybody in American healthcare, which is big gaps in big gaps in insurance coverage, people feeling really out of control. I think in America, we like to think that free enterprise, capitalism is popular because it gives people control. Well, I think you can think about healthcare and it's the complete opposite of this. Your employer every year says, this is your insurance plan. You look at it and you probably don't understand it and you're like, well, that sucks. And you just have to deal with it and you swallow it. And when you leave your employer for whatever reason, you're handed another health insurance plan if you're lucky, and you just have to deal with it. And you don't really have any choice or control in the matter. And you're subject to very random gaps in coverage that could hurt you probably at the worst possible time. Like when you lose your job, then you're thrown onto the individual market, which is really not a great place to be. The lack of control for individuals is the big problem in American healthcare. So the HPA rule was a rule that happened in 2019 that offers a way out of this. Employer-sponsored health insurance dominates American private health insurance, not because people love their employers picking their health insurance for them, not because employers particularly want to pick the health insurance for all their employees, but because of the tax exemption of employer-sponsored insurance. What the HPA rule does is it basically says to employers, you can give your staff pre-tax dollars in a health reimbursement account and let them pick the plan that they're going to be in. They can keep that plan when they move to a different employer or a different employment circumstance. That plan follows them. They're not forced to lose the plan. If they want to change plan for whatever reason, they can go to whatever other plan they go to without losing the tax advantage, which is substantial. The problem with the HPA rule is that the individual market's in really bad shape. And so even though in theory I think it's very appealing for an employer to say to you, here's the money we would have spent on your health insurance pre-tax, we're going to let you pick what plan you want to go in, it's up to you and it's going to be your money to buy a plan. You're then forced to go to the individual market where insurance premiums are sky high, way higher for equivalent medical coverage, insurance coverage that you would get by the employer buying directly just because the risk pool is so bad. And so this is a very unappealing place. The sort of, the sine qua non of health reform, I think in a long run perspective, has to be fixing the individual market. Throwing subsidies at it is not really a solution. The subsidies that the Affordable Care Act provided and also the Inflation Reduction Act provided were only affordable because the individual market was so tiny. Only like 8-9% of Americans are currently on the individual market. And it was a substantial figure. If we wanted everyone to be in the individual market, there's no way we'd be able to afford subsidies of the generosity of the extent that the Inflation Reduction Act provided. And so we need a more systematic solution. We need to fix the risk pool on the individual market. How do we do this? Well, I mean, I'm happy to talk about this. It's a longer discussion. But the basic problem is that insurance on the individual market is overpriced for people who sign up before they get sick. And so there is a gigantic incentive for people to not, well, even if you're sort of being charitable, it's overpriced. If you're being imprudent, you might have a case to wait until you get sick and then buy insurance, and you would get it on equal terms, which means, and we've seen this over recent years, that the average enrollee on the individual market is relatively sick. Healthy people aren't buying in. And so premiums are skyrocketed. The only way to fix this is basically to allow people a discount if they sign up before they get sick. You need to be willing to allow people lower premiums for signing up before they get sick. And the key thing is they get to keep the discount if they maintain continuous coverage. We had this attempt to force people to buy plans that were terrible value to them with the individual mandate. That simply didn't work because the mandate was basically a tax on the uninsured. And the uninsured are generally people in a really bad situation. They're poor, they just lost a job. And so even under the Obama administration, 23 million out of the 30 million uninsured were exempt from the mandate. It just wasn't doing anything. It was inequitable, it was unfair, it was hitting people who are already in bad shape. We need to sort of rely on the carrot rather than the stick. We need to let people get lower premiums if they sign up before they get sick. They will get into the market. That makes the individual market an attractive place of good value, with good value coverage for people to go. And it gives them a reward for staying there over the long run because they risk losing that discount if they let coverage lapse. That's the path forward. And I think it's an incremental challenge that we're capable of doing. And it's the way that we ought to go.
So thank you, Chris, for that excellent overview. I think that is very helpful to get us kicked off. One of the things you touched upon in your presentation was some of the differences in the utilization in countries that have single-payer insurance. I was a little bit curious around the issue of choice and really what in the countries who have moved with single-payer, what impact is there for individuals relative to the choice of physicians, and particularly in the area of specialty physicians?
Yeah, well, I think as a standard way of thinking about single payer is you got to imagine the whole country is a single staff model HMO. And so you imagine having an HMO, but there's only one HMO. And so you have things like you have gatekeeping. If you have to see a specialist, you will have to have a referral from a primary care physician. There will really not be an out-of-network option that you'll be able to access that will be in any way covered. And so you're very much limited. And so if there is a waiting list of 3 months, 6 months to see a specialist, that's basically it. There's no way around it. So you're kind of stuck. The primary care, I think, is generally reasonably accessible. The way to think about where the shortages occur are that the cheap services are fairly abundant. It's the expensive services that get cracked down on. So primary care, access to primary care physicians is generally not that bad in single payer systems, but specialty care, surgical care, many drugs, especially the expensive ones, can be a lot harder to come by.
And Nadeem, with the research that you have done on the international components of single payer, is your view similar to Chris's, or have you seen other experiences relative to the ability for choice for members within those type of health systems?
Very similar to what Chris has seen, certainly from the Canadian perspective. There are longer waits to get into a general practitioner in Canada than you'd find elsewhere in the developed world, so it is not as egregious a wait time as you might find for specialist care. Yes, in theory, Canadians do have a choice of physician, but there are no physicians to serve them. The physician opens the office, the roster is immediately full, there's no patients being taken. So many Canadians are stuck with no family physician. They're going to walk in clinics repeatedly and getting whoever happens to be serving patients that day. It's a real concern. And once you move forward into specialist care, you have a referral in your hand. One of the solutions to long wait times in Canada has been to remove the ostensible choice of your specialist physician and simply give you the first available to try and bring the wait times down, because wait times do vary between physicians. There has been general unhappiness. I think governments have backed away from that very quickly, very quietly. But certainly, we know there are differences between physicians, and in Canada, the ostensible choice is limited by access. Around the developed world, we're seeing some nations move more towards more choice. I think they're moving more towards market-based mechanisms, a little bit further away from the Canadian and traditional British model. That is not without cost, but it's certainly better healthcare for individuals. And so I think more and more around the developed world, there are great conversations in good times about what can be done to have a more patient-centered healthcare system with a little more expenditure. As soon as the bad times come back and the economic constraint comes back, we're right back to you'll go to your GP, you'll wait for the doctor you are assigned, and you will wait and wait and wait.
Well, and to follow up on that idea of when there is a downturn, since globally we're experiencing one or about to, depending on your definition of where we are. What has been the experience across the globe when there is, in fact, a downturn? You talked a little bit about perhaps the tightening up of the parameters. Is there other issues relative to the ability of the governments to fund a single-payer system when there are changes in the economy?
I think generally what you'll find, as Chris well pointed out, is that advanced medical technologies are less available in the government systems. More government, generally less medical technology. Generally the technologies that are available tend to be quite old. A lot of Canada's equipment, for example, is outdated at this point. As belts have to be tightened, we either get into more borrowing, which is future taxation, or we're going to come into a situation where rationing increases. Wait times will grow, advanced medical technologies will become less available, some services will be delisted from the governmental program, and off they go into the private marketplace. So certainly belt tightening, governmental systems are not immune from belt tightening. It applies to everybody, and in these systems there is no alternative or choice to go elsewhere. You're simply stuck with what the tightening is going to be. I think in Canada now, well, I don't think, we know in Canada now, the median wait time for an individual who identifies as ill, who needs to go see a general practitioner for referral, is 6 months from GP referral to treatment by a specialist for a non-urgent or non-emergent condition. That's an incredible wait time for hip replacements, for cardiovascular surgery, for neurosurgery. These are not benign conditions. And as things get tighter, those wait times will only expand as hospitals now start canceling surgeries to meet budgetary targets.
Somewhat ironic, given that one of the ideas of single payer is to increase access to care, and yet some of these examples really show limitations of access in certain situations. So, okay. Lauren, one of the kind of key components when you look at single payer is really for the government, whether it's at the federal level or the state level, to successfully negotiate rates. We heard a little bit earlier people talking about, what can we do with relative, opportunities to capping costs, et cetera. But how effective, or what are the challenges for the government to actually be in that role as being the negotiator of rates?
Well, it's not a fun role to be in. But overall, I think it's an important question, right? Because there's two questions. There's two paths you go down when you say, okay, we're talking about single payer. What is the problem you're trying to solve for? Is it an access question or a cost-related question? Then if you want to dig into that further, is it a cost-related question to what an individual pays out of pocket? Is it a cost to the system? Is it a cost to, through different payment mechanisms? What does that all really, really mean? And so as we've looked at different proposals across both nationally and in states, where the government's trying to position themselves where they're actually having success, and they had success in Colorado in passing I'll use air quotes, a public option, but it's really a rate-setting bill, is finding a way to try and control costs by tying specific populations that don't necessarily have coverage to specific rates and driving that down. Now, if you're going to sit there and start negotiating rates, that's going to have an impact on the care that you're able to deliver to the communities that depend on it, particularly in hospitals. Rural communities tend to get hit a little bit harder because they do have a higher population where they're going to require Medicare and Medicaid rates. And if those, and then obviously the private insurance makes up for some of that population that funds what they need to invest in to get the new technologies we're talking about to continue to be on the front end of that service. And so if you're going to start tying populations to these rates, that fundamentally changes the broader ecosystem of how healthcare is paid for. So we've seen this in Colorado. We've seen a public option in Colorado that really is a rate-setting bill. I actually in this country, I think we're going to see more of a conversation around rate setting because we're having a lot of conversations about costs. And ultimately, that's where, excuse me, Americans want to see a solution is how to drive down costs. So I'm very interested in, we've done a bunch of research we'll talk about in a minute, that does tie to the fact that we're going to have, if you're going to tie rate setting into a public option style model, you're going to have a $724 billion hit to hospitals over 10 years. Now, that type of number means 1 in 4 rural hospitals will have to close, and then you're going to go back to this access question at the very beginning when you think you're trying to solve costs. So you can try and squeeze the system, but there's something that's going to ultimately give, and you don't want something to give in the current model.
Thank you. Any other comments from the panelists on that topic? Okay. So the other thing that has come up is some of the, when people are saying we would have been better off having or we should move towards a single payer, is using the pandemic as an example, saying that if we had full access to care, if there was better coordination of care, we could have served our entire country better relative to the pandemic. I'm curious, what has been the experience of the rest of the world? So those countries who had single payer, did their citizens fare better than we did here in the United States?
I think there's a little bit of nirvana fallacy in the belief that the single-payer system can do better. Remember that coming into that, many of these systems were severely constrained in terms of capacity. So immediately the reaction was shut down elective surgeries, shut down less urgent surgeries, try to maintain ICU capacity. The demands for money came through, but the systems, the way they're structured, simply don't respond to finances the way a more market-oriented system would. One of my favorite examples from my home province in Canada, where we have fewer ICU beds post-pandemic than we did pre-pandemic, in spite of increases in expenditures. The Hospital for Sick Kids in Toronto is now canceling surgeries and canceling appointments again in reaction to the pandemic. This is not new. They were doing this in 2005 when there was no pandemic in reaction to government belt tightening. No matter what happens, children get less surgeries as soon as there's a headline that we can tie it to. Around the developed world, we've seen cancellations of urgent treatment. Waiting lists are expanding around the developed world. The Organization for Economic Cooperation and Development is now doing studies on how countries are going to come out of this mess, having delayed so many more surgeries. And there's a lot of examination being done about how many people died while they were waiting for care longer than they were already going to wait for care. In a lot of ways, it comes down to capacity and the ability to react to something sudden and severe. And we know when we look from outside to the United States, we see, and certainly that's not to say there aren't issues, but certainly we see from the outside a lot more capacity than we may have at home. And in a lot of ways, I think the conversation in Canada was the opposite. It was, yes, we have this government system, yes, we can do all these things, but goodness, wouldn't it be nice if we had the sort of access to hospital care they have south of the border, because at least we could look after everybody who happened to show up at the door and not hope there wasn't a car accident as well that night.
What I also think was really interesting in that moment is we talk a lot about how do we respond to COVID, and as a country, we did. We had testing, we had vaccines, we had masks, we have all the distribution to get people here what they needed, and our government was able to flex that muscle to do it. Then there was also this moment of, oh, everyone's going to lose coverage. We're hitting a recession, so we're going to lose a ton of coverage. Again, the current system we have in place that allows for Medicare and Medicaid and employer-sponsored plans and individual plans really came together and worked in a way where we now have an 8% uninsured rate. That means 5.5 million people got coverage when COVID hit. And obviously that's part of Medicaid because we were able to expand Medicaid to the populations that needed it to make sure that they maintain their coverage. We also saw approximately 2.5 million people, so an increase of 21% enrollment on the marketplace exchanges themselves during COVID. Our system, while there are different pieces of it, expands and contracts based on different elements. And we have that flexibility because we are not in a single payer model. We are not in a mode where one person says yes or no, or one budget line says yes or no. So obviously we have a lot coming ahead of us with the PHE likely winding down, and what does that mean with Medicaid and getting people re-enrolled. But at the same time, we have a more flexible system than single payer countries, so we aren't tied to one thing, or we aren't tied to a specific way of doing things. We have more levers to pull, and I think that's a story that people are starting to learn as we're coming out of COVID that is unique to our system. It's not perfect, but it did what it was supposed to do to maintain coverage and get people what they needed.
Chris?
Yeah, I think there was a sense in which, if you think one of the big flaws or challenges we have in American healthcare is we have a lot of excess capacity. I think in regular times, if you sort of think about the amount of times, say, just to give a very concrete example, an individual MRI scanner is used is much less intensive than, say, in Canada or Britain. The flip side of that is when the pandemic hits, you have great ICU facilities. And so, I mean, this is neither here nor there in terms of a system design point of view, but it does mean that we have more margin for error. And at some level, that is what you're buying with the additional cost. It is this, I mean, voters like having hospital capacity close to home, and the ability to have slack in the system is something that's valued. Might be a little bit too valued sometimes, but there was a fortunate aspect, at least with the pandemic, that we were more able to cope in that respect.
Oh, it's certainly overvalued. Yes, yes, very much.
We should also remember that Canadians are fortunate to have the United States so close to us because the United States has served as an emergency valve. When we've run out of ICU capacity north of the border, provincial governments routinely send patients into the United States when there are not enough neonatal ICU beds, not enough cancer treatment facilities to look after people. That is an opportunity that allows the Canadian system to further under-resource its healthcare system in spite of relatively high expenditures internationally.
It's a great point. Being in Buffalo, we see that on a regular basis of people coming across the border. Going back to, Lauren, something you mentioned earlier in your comments, you were talking about the impact on rural hospitals, for example, if we went to a single-payer system. I'm just curious for the panel's thoughts about across the entire provider system, so not only the hospitals, but whether it's nursing homes, the physicians, the impact upon future physicians, nurses, et cetera. Just curious what your thoughts are there.
Well, I'll go ahead and start and let you guys jump in too. We've done some research at the partnership where we've looked at the workforce impact. So as many, you guys are all in the healthcare space, many physicians are small business owners. And there's an incentive for them to go in and drive their own business. And if we go into a single payer system, there's a disincentive for them to go in and continue to practice where they are. We've modeled out we'd have about a 25% negative impact on physicians and nurses across the country over 10 years if you created a single payer model. Now, obviously, we're looking at that in a vacuum, and we looked at that pre-COVID, so things have changed, but I would say they've changed probably not for the better. We have a workforce challenge in this country, and we're seeing that across the board in nursing homes, in hospitals, in care facilities, and this is something that is obviously critically important to the way we all expect and anticipate the healthcare that we want and deserve. So I think there's a lot of unintended consequences when people ask the question, do you want universal health care? And the answer is yes. Everyone wants access to affordable health care that's great and good for them. No one's a no to that question, but we have to analyze the trade-offs, and there are huge workforce challenges to that.
So, I mean, you mentioned rural earlier, and so when we think about what single payer is going to look like, there's a single payer system that you would like to see, and then there's a single payer system that the political process is likely to generate. And if we look at how Medicare pays for rural hospitals right now, rural hospitals are on the old cost-based reimbursement system. They're paid a percentage of the cost, greater than 100%, and basically for the more costs that are incurred, the more the Medicare program will pay these facilities. As their volumes go down, their overheads loom larger, and they're paid more for each case. Medicare realized that this was a crazy thing to do many decades ago for the vast majority of hospitals, but it's never been able to sort of move to sort of fixed rates for the rural set of hospitals, the critical access hospitals. And so it's very hard to imagine what a single payer system with a rational rate setting basis would look like if we can't even do it in the Medicare context already.
Nadine?
I think in part the answer is remember that in what you might call a true single payer model where government is the payer, is the insurer, politics drives healthcare dollars. And there are very few voters in rural areas. There's lots of voters in the big cities. And it's all driven on a cost basis. Canada has a severe physician shortage, and we have had for many, many years. But that's actually the result of active government policy. It's a small government success story in Canada. In the 1970s, Canada had one of the highest physician-to-population ratios in the developed world. And there was a lot of concern about what that would mean for costs decades later. And so physician training was clamped down on, and we reduced the number of medical school enrollees, we reduced intake, and by the early 1990s, here we are with the physician-to-population ratio that is insufficient now. Government engineering is political, and it's often it is unable to account for all of the realities and complexities that the market is capable of accounting for when you have so many intelligent people doing so much work in so many different areas and competing with one another. That single model approach will lead to less access to services in rural areas. It's a reality in Canada, it's a reality around the developed world, and it's in part driven by cost and it's in part driven by politics.
And our study looked at this, and we looked at it and said, okay, $774 billion will be cut to rural hospitals if you tie to Medicare rates. And that's 1 in 4 rural hospitals will close. Now, it's an average and aggregate across the country, so it's not, I mean, it hits different regions differently than others. But that's a significant amount of hospitals in this country that people depend on. And the reason being is because just the rates themselves do not support the work that they need to be doing. They do not support the workforce that they are currently supporting. And so if we're going to talk about rate setting, we're going to talk about models of single payer, we're talking about public option, people aren't looking at the details and the trade-offs of how you're going to create, how you're ultimately going to structure something and pay for something like that. And 1 in 4 rural hospitals at the threat of closure is incredibly significant. I think people don't take that into account. They think, oh, well, I'll just be able to have this because I want to walk into this hospital, it'll be mine for free. And they're in a different spot than someone in a rural community who really, truly needs that hospital to be there.
And if we could, let's transition a little bit. You were talking there a little bit about also the public option. So when we're looking at the public option, a little different than the single payer. So that's having whether it's federal or state funded program alongside the private model.
Yep.
Sounds a lot more attractive, right? But what are the challenges that we would face with a public option that would be that broad?
Of course. Well, first off, public option sounds delightful. It's an option. We all love options. So it's branded beautifully. But I would say, I'm going to use the term, and I think we'll use the term pretty broadly up here, but there is not one single public option proposal that is the same as the next. So very drastically different models. Washington State has passed a public option, and I will definitely use air quotes around that one. That's contracted with private insurance companies who execute that on the marketplace, and that is their public option. I'll be honest, it hasn't been successful as a version of public option. It still costs more than a basic silver plan on the marketplace, and only 1% of the eligible population has signed up for it. They're still going with the plans that they want. So why, again, are we creating a public option with these requirements and then basically doing the exact same thing we're doing already on the marketplace itself? Colorado has passed a version of a public option. It's really rate setting, and that they're kind of working through the details of that. And in Nevada, they did actually pass a 5-year runway to get to a public option. However, with the political realities of last week, it's highly likely that's going to be abandoned at the cost of the cost to implement that. The only other state that has passed a version of this is Vermont, and they did not have enough tax dollars to fund it. So before they even got to implementation, they overturned it and decided not to do it. So it goes back to, again, what are you trying to solve with a public option? What population are you trying to make sure has the option of coverage? Is it everyone in the state? Is it the folks that fall in a Medicaid gap? Is it folks that are on Medicaid or on the exchanges that want another option? And all of these questions are trying to be asked. It goes back to the what are you trying to solve for? And so oftentimes we talk about public options, sounds great, right? We're creating more options for people to pick what they want and they need. But there are unintended consequences, especially the bigger and broader you choose to make that public option available. If you're going to make it available to everyone in the state, then now you're going back to this rate setting question we talked about earlier. We're talking about those reimbursement components of it. And ultimately, this is why we see a lot of discussion about public options. And then when states start to get into the nitty gritty of what this could actually mean or how this could be implemented, they kind of step back. It's because the costs, the challenges, the trade-offs start to become a reality, and people really don't want to do that, and they want to focus in kind of on what they have now.
Chris?
Yeah, I would say that a plan being the publicly approved plan by itself doesn't make it in any way different. Is it a plan with more money? Well, in that case, you have the conversation about where should we put extra money, which is the same conversation about where should we put extra money that you would be having with private plans. If it's a conversation about regulating certain provider rates, it's the same conversation about regulating provider rates that you would have with private plans. So I think I get why it was, if I was running in a presidential primary, it might be the way it sounds great, but it doesn't by itself actually change anything in terms of the real under the hood elements of healthcare policy.
And it sounds a little bit like a cautionary tale. The few states who have tried this have not really seen the cost benefit of that as well. It sounds absolutely, actually the opposite, correct?
Correct. The partnership, we advocate for building upon our current healthcare system. And the fact that we currently have 8% uninsured in this country is phenomenal. So let's figure out who that other 8% is that we aren't getting to, and see if that is a expansion of Medicaid, if that's an ACA subsidies component to change some of the elements of that. The other chunk of that 8% are going to be undocumented immigrants in this country. And that's a whole nother discussion, but creating a single payer health, we're in a different place on that. So there's a lot of questions of kind of who are you going after when you think about this public option, and are there other avenues that have proven success that have actually contained costs that we need to assess and analyze and look into, rather than saying, oh, well, we can't get to them, let's create something new.
Nadeem, you talked about before when we were talking about the single payer, some of the impact, your comments relative to the impact on the provider, the delivery system. With the public option, is there a different impact relative to delivery system, same risk, less risk? What's your sense of that?
I think when it comes to who is on the payer side, when you have multiple payers, when you have a real option, real competition, the providers now are incentivized to try and do better to try and attract payers in. As you grow closer to monopoly, it becomes a real kind of manager-subservient relationship, and certainly you'll find dissatisfaction among providers in that world as rates are set, as rates are fixed, as there are no alternate opportunities. What is very interesting in this conversation, I think, is a corollary, is the developed world is moving away from that sort of thinking. Increasingly, we're seeing countries like Switzerland, Germany, the Netherlands realizing that as you move away from government operation of insurance, as you move away from immediate direct government oversight, and in Scandinavia, as you move away from government being the purchaser and the provider and separating its roles, you get a better universal access healthcare system, or a better healthcare system overall to show for it. And at the same time, we're hearing debates here where the move is towards the things that the rest of the developed world has realized just don't work. We know, and we know in Canada, it doesn't work. Canadians are searching for an answer and having that debate, but it's patently obvious to everyone that the single-payer model, the government insurance model, has failed Canadians. The Brightons realized this in the 1960s, and they've been moving away from that model ever since, slowly and incrementally, more and more and further and further. Certainly in Western Europe, the moves are away from it. And at the end of the day, the providers are happier as a result. Government has its own set of incentives. They tend to be very politically driven. They tend to be very bureaucratic, simply as a function of how government tends to operate. As providers fall into that, their satisfaction levels fall. Their ability to control their day-to-day activities falls. Their ability to react to consumer demand or patient demand falls. As government steps away, those things all begin to improve. I think Sweden has some fantastic examples of what happens even when small things like government not owning a hospital changes. All of a sudden the nurses are happier because they can actually look after patients in the way they wish to, not based on the diktat of the local bureaucrat coming down. Certainly, the more government you have, the more governmental the system becomes. And as a general dynamic, that's going to mean more bureaucratic, less patient-focused.
Other thoughts?
One other element of this, which is interesting as we watch this conversation in this country, really, I think, developed from about 2012, 14, 16, particularly in 16, 18, 20. As more government gets involved in these decisions, in a more partisan divided country that we currently have, it's not necessarily the best outcomes for individuals. And so it's been an interesting kind of wave where we're having a very deep policy discussion. We're talking about costs, we're talking about trade-offs. The government involvement is a very important one, and I think one that's often overlooked about what would be considered in a basic health plan, what would be considered an essential health benefit, what is the baseline that we would have in this country, and no one wants to have that discussion. To say this is in and automatically covered and this is not, and this is what you're going to have to wait longer for. And I think as Americans, we tend to struggle with picking and choosing. We like what we have. We think everyone should have access to something like that, and don't want to pick that. So we have the policy discussion, and then no one wants to have this reality, like this conversation based in reality of someone's going to have to make a list of what gets covered regularly and what necessarily is a wait time. And that's when I think the rubber hits the road, and you're going to start losing a lot more support for single-payer systems.
Chris, other comments?
Yeah, I think increasingly, well, every country, the share of GDP spent on healthcare has increased. If you look at a lot of the single payer systems, they're around 7 to 8% of GDP, which is our level of public spending on GDP. So the question is really, do you take that 7 to 8% of GDP that taxpayers and government budgeteers are willing to allocate to public healthcare spending, and you take that 7 to 8% and spend it where the private sector can't generate funds?
Legally.
Or do you use that 7 to 8% and use it to displace the private sector? And so what you sort of find with Britain and Canada is you find the 7 to 8% stretch to cover the whole population. We cover this, we have take the same 7 to 8% healthcare spending, and we focus it on the poor, the elderly, the disabled, people who basically can't provide their own health insurance. And that means that you get all the private money as well, and so we're able to enjoy many more resources. I think that's the dynamic that certainly Britain is running into, and I get the impression Canada is that it's really hard to get above that 7 to 8% because then you've got education, you've got transport, you've got law enforcement, you've got people who are really upset about taxes, you've got people who start moving because of taxes. It starts becoming very leaky beyond that. And so it's really hard to increase the public spending. And so a willingness to say, we're going to keep the public spending over here and rely on private resources for the bulk of the working age population is an important element of allowing the inflow of resources in healthcare to increase. And there is growing demand for healthcare. People really, it's not like in Canada, as medical technology improves, the affluent middle class people don't want access to that. In fact, demand for healthcare increases faster than economic growth as a whole. There is a very strong latent demand for healthcare, even in the single payer systems.
It's like every week.
If you're trying to make the most of a scarce amount of resources, you want to allow this to be deployed as much as possible. You want to tap into this private demand rather than really just frustrate it, which is kind of a senseless thing to do from a policy point of view.
Term, right? To actually.
So, kind of going back to, I'm hearing, as we talk about whether single payer or we talk about public option, I think several of you or all of you have really mentioned in your answers or your comments that, are we getting confused with a concept versus what are we really trying to achieve? And if one of the things we're really trying to achieve is greater coverage, are there other approaches? So, certainly the experience we had during the pandemic when the Families First Coronavirus Response Act was in place, the number of individuals who received coverage that you earlier mentioned really went up significantly. Are there other approaches that we should really be looking at beyond single payer and beyond the public option to really continue to enhance the ability to have greater coverage, greater access for our population?
Who wants to go first?
Fire away.
All right. I think a lot of the pieces that were done throughout COVID, the various pieces, nodded to investments by this country that got a strong return on investment. And that included enhancing the marketplace subsidies, which gave people incentive to stay in. We have 3.2 million people in this country that pay less than $10 annually, or $10 a month, for their healthcare insurance for their families. That's a great benefit. And that's, to your point, we're using the 7.8% as wisely as possible in our resources to give as many people coverage without trying to bump that up higher and higher and cover everyone. I think that's a great step. I think, two, Medicaid. That's, again, I'm speaking to a room of healthcare people, but that's the big secret to the ACA. What's happening in Medicaid and the efficiencies that are happening there continue to get more and more people coverage. The innovation coming in Medicaid managed care and the options that are provided through that Medicaid are incredible. We still do not have all states who have expanded Medicaid, including two very large ones that have some populations that would benefit from that. I understand there's political reasons for that, but I do think that would continue to increase coverage as well. And then just continuing to look at how do we create efficiencies within the programs that we have. I'll also throw out one option that was discussed federally this last year, but I would not advise as a path forward. And was a robust conversation about moving Medicare aged from 65 to 60. And a lot of research is done around that, and what does that actually do? First off, that's big group of people who currently have employer-sponsored coverage from 60 to 65. So you're going to take a whole bunch of people that are currently paid for through the employer system or paid for by themselves and put that onto a government system. The Medicare Solvency Fund is not as strong as it currently it should be. So you're going to put a huge strain on that going forward. And then a lot of expectations of what Medicare does cover versus doesn't. A lot of questions about, are you talking about a Medicare Advantage style model for those 60 to 65? As you all know, that is drastically different than just putting people onto Medicare and giving people those options. So ultimately, those types of proposals have a huge cost impact because they fundamentally kind of change the private pool to the public pool, and what does that actually mean? So there's some unintended consequences there. But overall, those are some of the pieces that we've looked at and trying to find paths forward, but obviously you guys have some ideas too.
If I may, I think as we look internationally, it's important to understand the trade-offs, and there is no panacea. The idea that government stepping in can solve all problems is simply factually incorrect. But as we look around the developed world and we ask the question, how do we minimize these trade-offs as you move away from an enterprise-based model in the United States that delivers an incredible value for healthcare dollars in terms of access to medical technologies, access to advanced medicine, rapid access to care? How do you minimize that trade-off while trying to expand coverage? I think the answers seem to lie in countries like Switzerland or Germany or the Netherlands, where they've done very much what was recommended at the beginning, which is fix that individual market and allowed individual access into a competitive market and tried to ensure it, to ensure that those who don't necessarily have the funds to access the individual market are able to, and to ensure that the individual market has a set of regulations around it that secure access for those who are elderly, those who are more ill, and also ensures that those who are less elderly and less ill are still purchasing insurance and getting into that risk pool. It really is, I think, internationally about ensuring competition in insurance, ensuring competition in provision, ensuring appropriate financial incentives, and setting government to the right role, not a predominant role the way we see in Canada and the UK, where we do have failing healthcare systems, but in a role where government acts as a reasonably sized goalkeeper. We make sure that everybody has access to the individual market, we make sure they're active participants, but we do not have government operating insurance programs. We do not necessarily have government operating hospitals, or at least not all of them, and we allow individuals to make decisions about their own health care on a more private basis with taxpayer funds, 7 to 8%, that does seem to be a universal constant, 7 to 8%, ensuring that those who can't afford it get the resources to afford it and have access to that healthcare system. That seems internationally and factually, at least in terms of the empirical data coming out, a far better answer than having government-operated insurance programs and ultimately create rationing and unhappy patients, as well as fewer physicians and nurses to look after them because they exit the profession or aren't entering it thanks to government constraint. Chris?
I think the big source of a lot of our problems is the employer role in healthcare. Now, it's not just that people lose their health insurance when they move jobs or go to a different job or between jobs. But a big problem, and I think this is a real source of the cost growth, is if you're an employer, if you're an individual and you're buying insurance, well, you want a network that has your doctor, your local hospital, maybe a couple of specialty providers, and maybe a regional medical center. And that's it. You don't care about 99% of the hospitals in the country. So you would, an insurance network that does a good job of covering those providers and gives you a set of providers that are low cost is going to look great. And we see that on the individual market. Consumers are very price sensitive. Narrow network plan, 73% of people in the individual market go to narrow network plans because they care about cost. They really do care about cost. And these other 90% of providers, they don't care about so long as their core ones are at a good price. Now, the problem with employers is that even if I'm a mid-sized employer, all my employees, they themselves only care about these one, maybe two hospitals and providers. The problem is they're not the same ones. Different employees have different hospitals and different doctors they each care about. And so if you're an employer, you basically have to have all the hospitals in your network, and you have to have all the doctors in your networks. And the hospitals and the doctor and the physician groups know this. And they start playing hardball when it comes to negotiations. And so anything that they claim for, they want to invest in a new piece of equipment, well, it's going to get covered because I've got the employers willing to basically, I can name my price and they'll sign up. And so if you actually look at the amount of employer plans that even offer narrow networks, it's only 9% of employers that even offer it at all. Cost control is basically at odds with employer control of insurance, group purchasing of insurance, just because you can't have real negotiation with providers. So if we move to a situation, we've already fixed some of the tax obstacles to individual control of insurance. We need to fix the individual market as well so that people can actually go into the individual market and get good plans at a good price, because they're not going to be eligible for subsidies if they have an offer of employer-sponsored coverage. But if they're able to take the employer money to the individual market and get an individual market plan which is not destroyed by a bad risk pool, the individual market plan will beat the group plan on cost by about a third. And the growth path will slow even more over time. At the moment, like no hospital's thinking, oh, I'm not going to invest in excess capacity because I'll lose the individual market plans, because it's a very small segment of the market. The employer market and Medicare dominate investment decisions from a hospital point of view. So we need to move to a world where people can go into the individual market, flock to the low-cost plans that they care about, and then you start getting some price sensitivity into the system and everything can work in the right direction. But it's the lift politically. There are some obstacles. It can be done, though.
That is the lift politically.
So we have answered this thing, I think, to a degree, but want to make sure there isn't any other different nuances. So in New York State, we're actually very fortunate that we're down to 5% of the population that's not covered by insurance. So other than what we just spoke about, talking about it really more nationally, knowing some of the policies in New York, is there anything else that you think that we should be looking to pursue more aggressively in New York to close that final gap? Or is it, again, around things like the individual market and some of the other things that are already in place? So just curious if any additional thoughts relative to that.
I guess I'm the only New York resident on the panel, so
We'll let you take that one.
to go. Well, I mean, I think states are kind of in a bind under the Affordable Care Act. The Affordable Care Act is very prescriptive about the individual market regulations. The only things that states can't do anything to lower the cost of individual market plans or to alter the rating rules on the individual market plans in any significant way. They can't really fix the risk pool in terms of like getting costs lower. They could drive costs higher, essentially. What states can basically have a lot of freedom to do is put in more money. And New York's very good at that, obviously. Like, there's no state that spends more on healthcare on the individual market, and especially on Medicaid, than New York. So, I mean, I think at the state level, it's pretty hard to actually make progress. I mean, you can fill the gaps with more money, and I'm sure legislators are going to try to do that. But then there's sort of diminishing returns to that, right? It's like the easy cases are the first gaps you fill. The more you fill, the higher up the income spectrum you go, the more you start crowding out private insurance, and you start getting a lower return on your taxpayer funds. So I do feel bad whenever I go to state capitals, because I do feel like you're kind of stuck unless you just want to spit through more money at a bad system that has inherent inefficiencies to it.
So I would say I would agree. Whatever the low-hanging fruit that is left that you can use to the folks that fall in the Medicaid gap, try and get them coverage. I think the biggest thing that I'd also point to is just what cost containment and innovation can the state do. So if you're getting close, like you guys in Massachusetts, and there's a few states that are just really, really low on their uninsured rate, the next step is, okay, what are we doing to create efficiencies across the board? What are we doing efficiencies for consumers, for the system, that make us better and stronger? So that's the piece I'm always intrigued by, and I think that actually comes from the innovation of the companies that are part of the healthcare system, not necessarily a mandate or a rate-setting piece or a directive coming from state or federal governments. So to me, I think if you're coming at like a 5% and lower uninsured rate, my next question is, okay, what's the innovation that's going to help you be more efficient and how you deliver that more cost effective, and looking at proposals like that. All of that's to say single payer systems in that model, they feel like, to the point that you're a perfect example of trade-offs. It's like government should be in the place of minimizing trade-offs. And the trade-off of a complete disruption and overhaul of the system versus what are you going to do to get 5% people covered and create efficiencies, that seems like a really big trade-off that's going to have a lot of consequences. So I would say get 5 to 4% and then think about the cost pieces overall.
And I think it's important to recognize that as much as the single-payer systems and the universal systems around the developed world have everyone, quote-unquote, covered, the Supreme Court of Canada, no less, said that access to a waiting list is not access to health care in response to a court case in our country. Some 4% of Canadians today, as we sit here, are on a waiting list for health care with a median wait time of 6 months. And that adds up to a lost time value of somewhere around $4 billion. That would be $40 billion in the US, direct correlation. We have a tenth of the population. So there are some significant trade-offs from getting too aggressive, and also never forget, there are uninsured around the developed world in the universal countries. Those would be the undocumented immigrants, refugee claimants, and many others who simply do not qualify for the universal scheme. So I think it's very much an agreement. Overhauling the system to chase 5% is probably not a great idea when the overhaul of the system especially might leave you with 5% in a very different way, not getting health care.
Okay, I know we're getting a little down on our time. I have one more question that I'd have for the panel, and then I think we'll have time for perhaps a question or two from the audience. Well, so kind of flipping it around again then, if ultimately what we're driving to is trying to have more accessibility, which ultimately means more affordability, what are some of your final thoughts relative to things that we should be thinking about as we talk about really trying to have cost containment in the healthcare system in the United States?
I'll start from where Chris left off. The most cost-effective way to get a good or service is to have an individual spend money on themselves, not a detached where the government spend money on detached individuals, not necessarily the employer directing for the individual. And that individual market can be incredibly powerful, and certainly letting people have control of their own health care. The solution is not to put government in charge. That has not worked around the developed world, and there's nothing to say that it would magically work here for the first time.
I would say there's been a bit more of a movement on some transparency components, both on how patients are billed at a hospital through their insurer. I think the more that can continue to come to light, and you have broader health initiatives and education for individuals to pick their plans, to know what's in them, to understand their coverage, to pick what's right for them and their families, the more we're going to have people that truly understand that their own health care and how they need to take care of themselves. If people do that right, they will use the system more efficiently, and that ultimately saves all of us money. We have to get away from I need to go to the emergency room for care because I don't have a doctor, I don't have a family physician. There's a lot of those types of education components that can help drive that down, especially if there's more transparency in the system.
Yeah, I do think it's kind of go back to banging the same drum. I do think it's ultimately about letting people control the savings. One of the big problems with employer plans isn't just the network issue. I mean, we saw in the 1990s that managed care really did slow the growth of costs, and it really did drive efficiency. Now the problem is that the savings went to people's bosses, or it was passed on in terms of wages, but people didn't really associate the fact that wages rose in the 1990s with the fact that managed care was reducing healthcare costs. And so what people saw is they saw, wow, it's really annoying to have these claims reviews. Wow, gatekeeping's really annoying. Wow, these denials of care are kind of intrusive, or these paperwork requirements or whatnot. And so it's a very different environment if individuals are picking their plans. And you know that, okay, I'm maybe going to have to travel a little bit further to the hospital, but I'm saving $1,000 or like $5,000 a year in premiums. I mean, like, we're talking about big numbers. I mean, you look about the cost of surgery for like a knee replacement. You can have one facility that'll do it for $70,000 and one that does it for $30,000. Like, traveling is not a big deal when you have such a gigantic disparity in cost. And so what we need to do is realize that people will be reconciled to the fact that wow, that is a big savings if they can get the savings. If it goes to their employer, then that's a harder sell. And rightly so, right?
Similar it is in other industries, right? We make choices every day relative to the offsets between cost and convenience, et cetera. So, don't know, are we?
Don't know if we have any questions from the audience. If not, I just want to thank our panel again. I want to thank Mike for moderating. If you could all join me in thanking our panel and moderator.